Hello viewer, welcome to GBS TV. This is Health Talk for you. It's been a long time since we had such kinds of conversations, but as we live life, we realize that our health is such important to us, and it is important for us to look into matters that affect our health. Today I am joined by a doctor whom I'm going to give a chance to introduce herself before we take up the conversation for the topic that we have today. You're most welcome.
Thank you. My name is Dr. Stephanie Washira. I'm a medical officer, so I practice as a general practitioner for now.
Well, good to have you, Dr. Stephanie. Welcome to the show. So really, there are many health issues that we need to talk about. Currently, there's a lot of cancer, not only in the country, but also globally. There are many diseases. And I've had people say that they had better suffer from HIV and AIDS and not cancer. Because for HIV and AIDS, at least there's a solution. They have ARVs to take. And so today, viewer, I would like us to talk about the path that ends HIV and AIDS. I don't know exactly what path that would be. If I would pose to you that question, what do you think is a path that people need to follow to end HIV and AIDS?
Okay. So the path to end HIV and AIDS usually focuses on a couple of things. So there are levels to a disease, and there are points in which us as doctors, we say we can mitigate. There's a primary, the secondary, and the tertiary level.
Okay.
So for primary prevention, primary is basically talking about before you get the disease, what are the things you can do to make sure you don't get it. Those are the measures that now can help make sure that we don't have new infections towards HIV. So there's so many solutions to that. There's looking at your sexual behavior, addressing early debut, especially for the reports you were seeing, very young girls getting pregnant early. How do we address things like that? What are the preventative measures that people use when they are engaging in sex? Are there medications we can use to prevent the acquisition of HIV infection? They exist. So that's the level that we can start. Again, there's also a secondary level. When you do have HIV, then it does not need to progress into what we call AIDS, right? So having HIV doesn't necessarily equate AIDS. AIDS is now the more advanced form of it, if you could use that term. So when you get the infection, how soon do you start treatment? How consistent are you with that treatment? Because with the consistency, you can get, the virus you can get what we call viral suppression, which is its quantity is very low in your blood. So then you're almost living like you don't have
You've become
HIV.
a bit stable.
You've become a bit stable, right? But still on medication.
All right.
So there's that point. And then tertiary is now where we come in the event that you get complications or what we call opportunistic infections. Is there TB added on? Do you have a cancer added on to this? So the path that ends is us saying that now that we have medication that can mitigate from the primary and secondary level, then we can actually mitigate against advanced like AIDS complications and opportunistic infections. We can start to end AIDS early and treat it like many of the other ailments that we have seen come all the way to an end. So
I guess people would find this a little bit irrelevant that we are talking about HIV and AIDS in this era. Because this is something that has been there for a very long time, and the assumption is that people even know how to take care of themselves. So a lot of people expect us to be talking about the diseases that are just popping up and new things that are coming up, and not using this time to talk about HIV and AIDS. But surprising thing is that we have had latest reports that say in the year 2015 to just last year, 2022, people have been losing their lives every minute because of HIV and AIDS. How proven is that?
So, it's still a disease that is prevalent. So it is not something to be ignored as yet. I don't think we are at the place to say that, it's not the in thing so we can move on. I don't think we're there. Mostly because there's the burden of new infections that come up, especially around the young population. So we're talking people between 15 and 24 years. We've seen that age group still has a lot of new infections coming up. On top of that, there's also how are people managing their treatment? Do we have enough people on treatment? Do we have enough people who know their status? Do we have enough people who are consistent with it, that there is viral suppression? That now is what we are yet to really achieve. So we can't really say it's a thing of the past. It's still relevant, and especially because, I mean, how do we put it? There's the age of when most people start sexual activity, which is that bracket of new infections.
And they do that without knowledge.
Without knowledge, without protection. So we cannot brush it away, because it is definitely something that age bracket will come up against as soon as they start sexual activity. So that's why it's important to keep talking about it, so that when you do engage in sexual activity, you're aware of the consequences.
You know, when HIV started, if I remember, some people even called it a taboo, you know, in some communities, and it was such a cursed thing that you are HIV positive or you were suffering from AIDS. And this developed to the point that, because from their very first infections, the symptoms were so much exposed, everybody would look at you and they would tell that you were suffering from HIV and AIDS. And it was so clear, you couldn't hide it. People knew. And I think I like that because it kept people afraid and cautious. So if you saw that, if you saw the pimples and all that on somebody's skin, then you would tread so cautiously and carefully. But now came ARVs, and people who are positive look as healthy as you and I look today. And you cannot tell just by looks that this person is sick. And that became kind of deceptive. And so people just got more and more infected. I guess that in those days, it was a little bit suppressed, because then people were scared. As much as you wanted to just go sleeping around, that put you off. You kind of relented. But now when it's all hidden, you really don't know. Do you think that that was a good thing for you, or it was so negative?
So, okay. It is a good thing. It is a good thing, because we definitely did not want.
What is a good thing? The fact that ARVs came.
ARVs have come.
All right.
Yeah.
All right.
Because especially in terms of improving life expectancy, when you have an illness like that, you know. So before, it used to be like what we would term a death sentence, or at least initially, medication was very expensive. It was not accessible to many people. It was cumbersome. So you're taking like 3 medications a day, you know, so then that is quite tiring. But now it's 1 tab a day, and when you take it consistently...
Oh, it's 1 a day.
1 a day,
wow.
And if you take it consistently, you're okay. So at least that shows us that we're at a place where we can manage it.
Okay.
Now, it is not to be assumed that now, because you're not seeing full-blown AIDS the way we used to see it, that it does not exist. So I think I agree with you on that point, where, you know, people are almost making statements like they're more scared of pregnancy than they are of HIV. So there's that lack of really understanding that, you know, this is a lifelong, it's a chronic illness still in itself. So even if it's manageable, it's not something to be taken lightly. So maybe we don't need to see the effects, but we definitely have to now keep having that conversation. And even as we are talking about sexual education, we are still talking about, hey, there are infections that can come about. So it's not just about pregnancy, there's infections, there's, you know, so much else around the idea of sex. That
Stephanie, let's get back to the report released by the UNAIDS. So there is 95, 95, 95, and that is to mean that 95% of the continent or of the country know about their status. Yes, they have been tested, and 95% also are on controls. They are on HIV, ARVs, and the other 95% have gotten to the level where they have suppressed the virus. And in Kenya, when the report was released, that 95, 95, 95 is the target that the globe has. But in Kenya, it is 94, 94, 89. Yes. What are we lacking? Why haven't we gotten to that target?
To the target.
Yes.
Okay. So at least we could say we are close.
Okay.
We're doing
Yeah.
well,
I think
reasonably.
so.
But a few of the hindrances would be in Kenya right now. So we can say one, we see particular populations have been catered for better than others. I'd say women, especially in the reproductive age, that's between 15 to 49, when you get pregnant, as you go for antenatal clinics, that is something that is checked mandatorily. So then you are able to catch infections in women and start them on treatment. Now the lag is the male population, because you don't have, well, let me say, an ideal like that to say that every man at this point can come to hospital and be checked. So it's either the initiative of now the woman, as she's being tested, she should come with her partner, and as well now that drive and awareness to let people know, hey, go get tested and know your status. So there's that. So for the male population, that's where you can see a lag. The other one of the statistics that's quite low, like in our setting, we have only 89% of people on treatment who are virally suppressed. The understanding is also that in terms of children, that is where control of the illness is still lagging behind. I'm not sure yet if it's concerns about now putting children on the medication or things like that, but it could also be related to certain practices, breastfeeding, and also our mother-to-child transmission. But that is what we tackle when we ask a woman to come early and be tested. So if you started on treatment while you're still pregnant, and then also through breastfeeding you're on treatment, then that reduces the risk of passing on that infection to your child. So just looking at now the areas that we can improve access to these services for children, and then as well bringing the men on board can help now drive us now into meeting that target fully.
How do we do that? How do we bring the men? Because when women go through the antenatal, then the men always say, you just go. If you're fine, I know I'm fine. You know, that's what they say. And that brings me to this point where we have a lot of discordant couples. I honestly wonder how that happens. And I know that a viewer could also be wondering. The thing that you get to hear is, I want you to be my partner, but I am putting this condition. Let's go and test. If you are positive, then we end it here. If you are negative, we can proceed. But how comes you test negative and I test positive?
I mean, yeah, it can happen based on, I mean, your histories before you met, if, you know, the person had acquired it before coming into this relationship, something like that. But yeah, I mean, so it is possible to have several discordant couples. And there's a way to proceed past that point of when you're serodiscordant, depending on how well committed you are to the relationship. So if your partner is positive, that doesn't mean that now we need to go our separate ways. Yeah, there's ways to manage the transmission from the positive to the negative person. And that's where now antiretroviral drugs come back into play.
When people take ARVs, they don't infect each other?
They don't infect each other, yes.
They don't infect others? Yes, please explain.
Okay. So
we are about to go on a break, so I would like to hear that.
So it's not that you don't infect each other. What happens is when you achieve viral suppression, which means you've taken the medications consistently, and then we test after 6 months, we see it's low, then we confirm again after 6 months, it's still low. Usually at that point, it means the concentration of this virus is quite low. Your risk of transmitting while you still remain on the ARVs and you have viral suppression is lower than a person who has not been on treatment.
Lower but possible.
Lower, yes. I mean, it's not necessarily 100%, but it's very low. It's low to the extent that actually, if you are virally suppressed, that is the point when you can try for like a pregnancy and things like that, and then still, you know, go through the journey taking ARVs through the pregnancy and get a child who is not HIV positive. So you see, so it's low enough that you can actually build a family.
But getting a child that is negative is not dependent on sleeping with a partner who is negative, because the negative or positive result in a child is dependent on the point of birth, is it?
No, not necessarily. I don't know what you mean by the point. So usually it's the mother who would be able to transmit it.
Yes, during birth.
Yes, during birth, during breastfeeding, yes.
Yes.
So what I'm saying is, like, if you're a couple that is, one is positive, the other is negative, when the one who is negative is virally suppressed, then the risk of transmission is low. But it's not just that. The negative person will be put on medication that now is PrEP, pre-exposure prophylaxis, because you run a risk of getting HIV infection. So both of you will be on ARVs, but for different reasons. This one to bring the viral load down, the other one is protective.
We are taking a short break. I hope that you are following keenly on this conversation. If you have any questions, please do text us and we will get back to you with the right answers. Coming back shortly.